Hi, this is Herb Kressel, editor of Radiology, and welcome to a special edition of the Radiology Podcast. Today I'm joined by two of the authors of the 2016 Margulis Award-winning research paper entitled The Radiogenomic Risk Score, Construction of a Prognostic, Quantitative, Non-Invasive, Image-Based Molecular Assay for Renal Cell Carcinoma. And joining me today are Dr. Nina Jamshidi, clinical instructor in the Department of Radiology at UCLA, and the senior author of the paper, Dr. Michael Kuo, associate professor of radiology at UCLA. Welcome, Dr. Jamshidi, and congratulations.
Thanks, Dr. Kressel. Great to be here.
And welcome, Dr. Kuo.
Hello.
Hi, good to see you again. So I think for many people, this will be a somewhat complicated paper to understand, and I would imagine many like myself will have the same question. How did you ever get into this line of research, and what are your backgrounds? So let's start asking both of you, what is actually your background, and let's start with Dr. Kuo. I remember the first paper I heard from you was while you were in training at UC San Diego, looking at liver tumors, if I'm not mistaken.
Correct.
So how did this all happen?
Well, this actually that was when I was at UCSD in my first faculty position as an assistant professor. This research actually started when I was a resident and then subsequently a fellow at Stanford University. There was a lot of research that was going on in this area of gene expression profiling and genomics, and it was just a great opportunity being at the right place, the right time, and being surrounded by just really intelligent people. And I just got involved and just asked a simple question, and then it just kind of started from there. And then I started that as my initial project and research focus when I joined faculty at UCSD, and have just continued to build and focus on that area for my career over the last 10 to 15 years. So it's been a great time. So
Dr. Kuo, I mean, a lot of the techniques that are used in the profiling and winnowing down all of the large number of variables are methods that most radiologists are not familiar with. Are you self-taught? Did you have any training in this?
I mean, by definition, to a degree, you had to be self-taught. This field really has just kind of exploded in the last 15 to 20 years. And so when I first got involved, I mean, the field had only been around probably about 5 or 6 years. So while there were many people who were well versed in the area, it was a small group, and so but there weren't really any formal training programs in that. So I just had to kind of learn from different people that were involved in the field over the course of time, and then obviously I've had to adapt those techniques to our specific area of research.
Dr. Jamshidi, how did you get hoodwinked into working in this area, or is this something that you've studied formally?
So I did my MD PhD at UC San Diego in bioengineering, and my research areas were primarily in the areas of mathematical modeling, kind of engineering, biochemical engineering approaches, so biochemical networks and that type of thing. And so the mathematical techniques have kind of broad applicability. But it was during the training time that I actually first met Dr. Kuo, and after he had done his work with HCC that you had mentioned, it was really kind of seminal work in that, aside from being a very nice study, it posited a very interesting question, I think, that I kind of like refer to now as, I don't know if you feel like it or not, the radiogenomic hypothesis, with the premise being cellular processes. So the area that I was kind of working with, all these omics type data, can be manifested on the kind of centimeter to millimeter scale that clinical imaging is done. And so then one can draw correlates or potential parallels between them, which is, if you think about it, this just totally makes sense Again, you're probably going to find some exceptions, but especially in cancers, malignancies, you're going to see this. And at that time, of course, I didn't know anything about real clinical imaging, but I understood some of the omics. So it just became an exciting area, to kind of learn about and go forward with. And that was kind of when I first met Dr. Kuo. And since then, we've worked together, and he's really been fantastic in terms of, I think, early on seeing the potential in bringing these areas together.
So this is sort of a corollary of the old saying, form follows function.
Yeah.
But you're dealing with function on a totally different scale than we thought about originally. Well, Dr. Kuo, as the granddaddy of the field, why study renal carcinoma?
Well, renal cell carcinoma is just, it was an interesting model, and it was also just really a confluence of people that came together at the right time and resources that came together. As I mentioned earlier, I think that a lot of this work really is driven by the people and the ability to find people that are of like mind, have similar interests and curiosity, and that also have worked in the area and have resources. So in this particular case, there was a paper that had come out in about 2005, 2006 from a group in Stanford that we've collaborated on this paper, who are co-authors and key members of our team for this paper, that had done some initial work in renal cell carcinoma, and we were very interested in this question of being able to construct quantitative imaging assays for different malignancies. And so this presented a great opportunity to work with a great team of people, and who had also great data resources. And so this is what instigated this process. And then at that point, Dr. Jamshidi was I believe a medical student, and there was some Matt Sapala was also a medical student at UCSD, and just really recognizing that these were just very bright and intelligent people, and just really trying to actively get them involved in these projects, recruit them, and they've just kind of them and a lot of the other people on this paper were really just key to really driving this project forward. It was a multi-year effort, but I think it was well worth it.
So tell us, if you would, what you did in this study. I gather you started with a score looking at gene expression data that relates to biologic behavior and patient outcome. And your goal was to try to match this with an array of imaging findings. And how did you go about doing that?
Yeah, so a lot of the radiogenomic studies to date had been based on taking the imaging data and the molecular data, most commonly expression profiling data, and creating the map and then correlating with outcomes. And the idea initially posited by Dr. Kuo was, well, what if we start with a signature and generate, so we have a molecular signature and we generate an imaging predictor that tracks that and then try to validate it. So it kind of rearranges and modifies that original hypothesis and shows the specificity. So in this case, Rob Tibshirani, a well-known statistician at Stanford, had developed this SPC score for renal cell carcinoma. So that was in part a motivating factor. It was a great study published in PLOS Medicine. And so we targeted that as our signature, and a series of features, a feature library was constructed with Dr. Kuo in conjunction with other radiologists. So Leila Agnovich, who was at UCSD at the time, and Ron Korn out in Arizona. And we used, there are all kinds of, you mentioned, there are all kinds of methods actually it can be applied to investigating these. And Matt Zappala, who was also in the MD PhD program there, had developed this method for basically rank ordering and reducing a set of large variables, and we applied that method to rank order the features that we were interested in, and that kind of set the stage. And then we were, of course, working with, there's a medical oncologist, Eric Jonash, out in MD Anderson, and Borje Klingberg, of course, in Sweden. Mentioning all these people in part just to highlight that these are multidisciplinary, interdisciplinary studies, and often it takes, the contribution and work with a lot of different people, again, over time. But sorry, the new or variation on the hypothesis, the standard hypothesis is, can we target a signature, track it, and validate it? And the surprising thing in part was the validation actually was a little stronger than I think we had anticipated, which you don't always see.
Right. Now, just to go back, the SPC, the renal carcinoma specific SPC risk score, has it been used clinically? Is it a helpful tool, or is it sort of just an outcome of a research study that is looking for a clinical application?
I'm not aware of any clinical trials that have been used for it. Something to note is, whereas in comparison to the omics fields, clinical imaging is well established in trials and everything have gone, but a lot of the profiling of transcripts is kind of something that changes year to year. And so from the time that study was initially published to the time that we did the validation, the human genome annotation had changed. So the actual chips to validate had changed. So the number of genes that were originally there is almost cut in half.
Okay.
So again, this is kind of a dynamic process, and it part of highlights the benefit of, the imaging surrogacy, because we have kind of more comfort with that, and it's a little more established. Sure. So find the imaging surrogates, it might be a more robust biomarker over time.
So tell us a little bit more about the image feature library you developed to categorize the imaging features. How many features were in the library, and how did you choose the specific features to look at?
The library had 35 features in total. At the time, again, when I was introduced in the study, I was a lowly medical student, so I wasn't involved with defining those. It was Dr. Kuo who had done those, and they ranged from some quantitative features to enhancement characteristics, to other things, or stage-dependent features, such as renal vein invasion, but those were removed when we constructed the final predictor. I don't know, Dr. Kuo, if you had additional comments to add.
Yeah, I mean, essentially, at this point, we had had some experience looking at or performing similar studies in other tumor types, and so we were beginning to develop a knowledge base of relationships between imaging features manifested on different modalities and their gene expression patterns and clinical outcomes. And so we were beginning to refine and curate a knowledge base of imaging features, so that instead of coming in with hundreds or thousands of features as is sometimes a tendency, and maybe an easier way to do it, because you don't have to necessarily think about it as much, we had refined and narrowed it down to a very targeted group of features that we had often seen to have important relationships. And then that way we can kind of, in one regard, really specify the question and limit the multiple hypothesis issue, because we're really focusing on a core group of features that seem to be relatively conserved across different tumor types, different modalities. And so that was really a key driving force for the selection of the features.
Now, the data that you use both in the test set and in the validation set has been accrued over fairly long periods of time, and it's likely that the specifics of the CT technique have varied somewhat. So how might variations in technique in the imaging data you had affected the development of the image feature library? For example, variations in slice thickness, or for contrast enhanced exams, the number of different phases that you imaged? Did you have to account for that, or how did you deal with that issue? Dr.
So
Jamshidi?
So some of these traits were basically, as we say, kind of expert-read traits. So it's dependent on the radiologist kind of reading them. And so again, not all scans were possible to be done triple phase. So some of them were just done in the portovenous. And so that often relied on the interpreter to make that assessment. And again, that cuts to this issue. It's an important one where when we all ultimately want to move to automated segmentation and imaging techniques. But one of these, accounting for that difference is easier by humans than the segmentation technique. So this was something that was accounted for by the individuals, and our kappas were in the 0.7 to 0.8 range. So we're pretty confident, we're at least happy about that after being trained that radiologists can make that distinction.
So there was some expert kind of input into the application of the criteria. So someone with some experience would look at it and say, based on this technique, this fits this feature or not.
Yes.
I see.
And I would just...
And then, yeah.
I would just add to that. I mean, I think that, as Dr. Jamshidi was mentioning, we were using a combination of features that were some that were quantitative, some that were semi-quantitative, some that were expert-driven or qualitative, and that those expert features are generally well understood features. These are not features that are what I would call very low level or very fringe features, and I think that does drive ultimately, to the point that we do want to get to more machine learning perhaps or automated features, and we've shown that that's possible in one of our previous podcasts. But I think that that there's still quite a bit of room on the human side. I think there's still quite a bit of gap between some of these machine learning based approaches and what a human can do with a set of well-defined features.
Yeah, I don't doubt that. Now, many people who will be listening and watching this are not really familiar with how you analyze the gene expression. Can you briefly summarize what that entails, how you develop these gene libraries that went into the risk score originally?
So that part in this case was a little simpler both simpler and more complicated. Simpler in the sense that the gene signature had actually been defined in a previous paper. So we were relying on that. And in that paper, they went through and did all the multiple hypothesis correction and controlled for the FDR and everything. The only difficulty, or the principal difficulty for us when we were translating this, essentially it was an algorithm that you could apply to the data, was how we account for the missing sets of genes that were not present in the validation set. And so that's where Rob Tibshirani's expertise in particular helped out, since he developed the original signature. But yeah, in this case, and this gives kind of an example of eventually where we'd like to go with some of these genomic signatures is, you kind of do the initial study, develop it, validate it there, and then make it available as a tool so it can be applied, as a script or what have you in a later study into other studies. Okay.
Now, you mentioned sort of the multiple comparisons issues, and I know a lot of people are not familiar with this type of study, are quite daunted when you look at, hundreds of genes and dozens of imaging features, and you're looking for significant relationships in, 50 or in this case 70 patients. So it seems like a daunting task. How do you approach this on a mathematical basis?
Again, so for the SBC score, that was actually accounted for when it was initially developed. So once the test is developed and validated in that set, all we have to do are measure those sets of genes. In this case, it was about 260, but we had about 140 or so that we really focused, that were still basically present in the current annotations. And for the rank-based image clustering, from a high level, basically, the data is reduced from the connectivity matrix, and then F statistic is estimated from it to account for the inter-observer versus inter-individual variance, and to go from there. In general, just in terms of the mathematics of accounting for this, the Bonferroni test, which we didn't need to apply here, is probably the simplest test, but it's a little bit of a sharp edge. It becomes then an issue. Again, we don't want to bore everybody, but you want to keep the p-value low. But now the issue of the false discovery rate is also something that you want to control for in these studies. So it's somewhat of a case-by-case basis. You kind of have to look at the data that you have and where you want to go with it.
You have to have expertise in this, or are there software packages that can help guide you through this?
I'm personally of the belief that you want somebody who at least knows and has some expertise, because it's great to have the software packages because you know what is being done, but you often want to make sure that you're using the right package and you're using it in the right way. So
I'd just like to add to Dr. Jamshidi's comments that essentially in this case, I think there's sometimes a tendency to try and come in with a lot of data saying we've looked at a lot of genes or we've looked at a lot of imaging features. And I think that at some level it can be prudent to start with a very small and simple focused question. In our case, as Dr. Jamshidi mentioned, we had a very simple defined gene expression set. So we were looking after one single target. And so that significantly reduced the space from thousands of genes down to one single gene expression target. Similarly, we tried to maximize the number of samples on the training set to 70. And then we also had an external validation set that's completely independent of 77. So we were able to mitigate along different dimensions. And then we also applied statistical testing to accommodate. So we had multiple levels to account for this, and I think that really the key is just having a simplified approach so that you don't get bogged down by these burdensome statistical questions that can be very complicated at times.
Good. Now, you developed something that you call the Radiogenomic Risk Score, or RRS, and what does it actually represent? What were the key findings when you mapped the image features against the genomic expression that was scaled by tumor behavior? You developed a score, and tell us about that.
Yes, so the Radiogenomic Risk Score basically is a selection of the top stage-independent imaging features that correlated with the SPC scores. So basically, it correlated with the transcriptomic signature we were trying to track, and it was predictive of survival. And so, in a sense, this is kind of an independent, non-invasive surrogate. And we since the number of genes actually that we had in our signature were reduced, we didn't necessarily expect a perfect correlation, and it was an all right correlation. But I'll get to that in a follow-up statement. Sorry. So, but the features that were identified were basically necrosis and then 3 different enhancement characteristics. Basically, we can phrase these in different ways, but some subsequent analysis kind of highlighted some immune and inflammatory components. So we kind of viewing this from the perspective of, self non-self interactions. If when you look at malignancies in terms of another a non-host growth, we can kind of view these enhancement or rim characteristics. So
what were the enhancement? Necrosis? Necrosis was one. What was the
Necrosis was one. Enhancement, so whether there's a sharp demarcation, so kind of essentially whether the tumor is infiltrating or not, and whether there's a hypoenhancing rim or whether there's an enhancing rim.
And with the score, do you get a point for each feature, or is it a combination? How is the actual score generated from the
score is a linear regression equation. And what we show in a follow-up study actually is that even though the weights on those are different, depending on what your other features are, you can be placed into a high-risk or low-risk score. So it's not just a strictly linear type of situation, but depending on your necrosis, whether you have necrosis or you enhance.
Just to remind people that the relationship between the radiogenomic risk score and outcome was independent of tumor stage. That relationship was independent of tumor stage, which I think people would be asking about.
Yes, absolutely. Yeah, that was.
And then just tell us a little bit about how you validated. Once you came up with the score, you had a separate validation set?
Yeah, we had a completely independent validation set that was the same size as our training, ultimately the same size, which was in part supported by the SIR. I have to mention that as a graduate medical student that supported the transcriptomic profile. So basically we had the signature defined, we had the traits of interest defined, and again, this is what Dr. Kuo was mentioning, so we're not going through the whole process and retesting all the traits. We knew the traits we were interested in, we went after those, used those to give scores for the RRS, and then calculated the SPC score based on the transcript profiles and retested the correlations, and we were pleased with the Kaplan-Meiers, honestly, I should say.
Yeah, I was very impressed with that. So do you think this radiogenomic risk score could be used in any way clinically?
I think potentially. We have a follow-up study in European radiology that applied this to a phase 2 clinical trial looking at Avastin treatment before cytoreductive therapy. And in part, this is kind of where we were wondering, there's this close correlation with the SPC score, but it's not perfect. So, do these features really represent something in addition? And it turned out that these were predictive of outcome with respect to treatment response for Avastin or bevacizumab, which was really exciting. That was part of, there are a couple things going on in this study that were kind of exciting and in part kind of encourage us to think that there might be some legs on this potentially.
Good. Now, where's this all going? What's next? What's next up for you guys?
There are a lot of different areas. One is it would be interesting to continue to test this in larger studies and potentially other contexts. It's something that we haven't done. I mean, initially when we designed the score, we wanted to demonstrate as a proof of concept that it could create an imaging biomarker that didn't include stage-dependent traits. But there is this question that, okay, we showed that concept. What if we introduce some of these stage-dependent features? Would that give even more power? Then there are some other thoughts on getting down to more mechanistic modeling and linking those and finally, this is a bigger, broader question, but as you alluded to earlier, the issue of moving towards automated or machine learning approaches. But I think that the big issue there is the segmentation, getting really good segmentation of the kidney so that we can have accurate feature detection. But those are somewhat bigger, broader goals.
Yeah, we've started to see a bunch of submissions trying to integrate key clinical biomarkers with the genomic data, with the imaging data, to get sort of more power into the model or scale that's been created. Dr. Kuo, where is this all going?
Well, I mean, I think that it's an exciting time. I mean, there's a confluence of these different technologies, and they're beginning to show robustness and utility in the clinical space gradually over time. I mean, as you know, these things take time for new insights to gradually embed themselves into clinical practice. And so we are continuing to pursue multiple directions, looking at these relationships, these multi-scale relationships between what is seen on imaging at an anatomic, structural, functional, physiologic level, and how that relates to the hierarchy, the structural hierarchies that are embedded at a tissue, cellular, and genomic level. And so I think it's a very rich space for biomarker development, mechanistic studies, understanding treatment responses. And so we're continuing to dive along multiple dimensions and trying to push the field forward in the best way we can.
Great. Well, I want to thank you both for a wonderful paper and congratulate you again on the Margulis Award. And we look forward to hearing more from your group and wish you well in your future endeavors.
Thank you
for joining us.
Thanks for having us. It was a pleasure. Thank you.